So hey everybody, I'm Sarah Searle. I'm a senior manager at BO Systems. Really happy to be here today facilitating this breakout session. And I have the distinct honor of introducing Marla Shavitz and Dominic. Is it Shattuck? Dominic? How do I pronounce this? Okay, great. Marla is the Director of Digital Strategy at the Johns Hopkins Center for Communication Programs. She works closely with the center's leadership team to identify, analyze, recommend, and execute digital technology priorities and vision. And since joining CCP in 2013, she's been instrumental in a number of digital initiatives, including the development of numerous websites, mobile applications, and data visualizations, as well as instructional design content. In 2017, Marla led the team that was a Webby Award finalist for the digital documentation of CCP's work in West Africa during the Ebola crisis. And Marla, I did not know this fact about you, but this is probably the coolest piece of a bio I've ever gotten to read. She also Unicode Consortium advocating for a mosquito emoji, which was approved and implemented across operating systems in the fall of 2018. That is just the coolest ever. And most recently, she's been the technical lead for a series of data visualizations resulting from a global study on knowledge, attitudes, and practices around COVID-19. Dominic Shattuck is the Director of Monitoring, Evaluation, and Learning for the Breakthrough Action Project at Johns Hopkins Center for Communication Programs. He also co-leads the Knowledge, Attitudes, and Practices COVID survey and data utilization efforts in partnership with Facebook, MIT, the WHO, and I actually don't know what this organization is, but GOARN.
Yeah, GOARN. We'll get to that in a minute. Yeah.
I suspect we'll learn more about it. Yeah. Since the COVID-19 pandemic began, his work informs global program implementers and policymakers about risk mitigation behaviors and trends related to vaccine acceptance. So we're so happy to have you here today with us, Marla and Dominic, and now I'm going to try and present your presentation. So turn off my video, comment, and share my screen. Okay, can you folks see my screen?
Yeah.
Yep.
And now I'm going to present and tell me if it goes full screen.
You're good.
Yeah.
Okay, great. Just tell me when to advance, Marla. Thank you, everybody.
Okay. Again, thank you, Sarah, for the introduction, and thanks everybody for being with us today. We're really excited to present this. Next slide. This was our introduction slide. So again, Sarah, thank you for your introduction. Again, my name is Marla Shavitz. I'm CCP's Director of Digital Strategy and was the technical lead on this project, which we call KAP COVID, for knowledge, attitudes, and practices around COVID-19. I will turn it over to Dominic Shattuck to introduce himself and get us started.
Yeah, thanks, Marla. So I'm Dominic Shattuck, Research and Monitoring and Evaluation Director for the Breakthrough Action Project at CCP. And today we're going to go through a little bit of the background of the dashboards. We'll talk some about the partnerships, the data that's collected, and Marla will really walk you through some of the visualization techniques that we use to bring the data to life and really make it interactive for the users. And then we'll talk about some of the use cases and instances where these data were seen in the actual policy and programmatic implementation in the field. So yeah, if you'd go to the next slide, please. So as the Director of Monitoring and Evaluation for the project, I'm responsible to show our funder, USAID, that we're actually doing our work. And so in mid-March, Johns Hopkins had implemented some guidelines restricting in-person data collection and program in our data collection and in our program activities. So as you all remember, back in mid-March of 2020, the world was changing and our projects and our programmatic work was changing. And it was clear that we'd begin to rely more on mass media and social media. The problem I faced was that our funder, USAID, did not have standardized metrics for collecting social media data. And so as we kind of thought through this problem, we started to network and make contacts at Facebook through our colleagues at Johns Hopkins. And I reached out to some people working at Facebook to learn more about how that would best be done. And these connections started an important chain of events. And so our team with the Facebook Data for Good project, which some of you may be aware of, they were looking for a partner who could leverage their global presence to increase data utilization of a global survey focused on behaviors, attitudes, and practices, knowledge, attitudes, and practices. Should we go to the next slide, please? Our goal was pretty straightforward. We were looking to increase database decision-making related to COVID-19 SBC interventions. And although media outlets like the Washington Post and the New York Times write articles on COVID trends in the United States, low and middle income countries often don't have the luxury of professional polling agencies to track behaviors related to prevention. Our work was done in collaboration with Facebook, it's Data for Good organization, our institute, the World Health Organization, the Global Outbreak and Response Network, a group that you may not be familiar with, but you're going to learn a little bit more about them in a bit when I start talking about RCCE committees, and the Massachusetts Institute for Technology, or MIT. And since June, this team has worked to develop and implement this study in 67 countries. If you go to the next slide, please. So what's important about this one real quick kind of identifier for the data that we're going to share today and the dashboards we're sharing today is that we have two types of countries. We have countries that were that provided 19 waves of data. And so those 19 waves, there are 23 countries that provided 19 waves of data starting in July and just now ending at the end of March. And then there are 44 countries where we collected data from them at the beginning of July and in November. And so the question I get often is why did you choose these countries? Well, these countries were chosen because Facebook understood that they had a large enough Facebook presence in those countries to actually provide a robust sample for this survey. And thinking that the multiple iterations of data collection, they would get enough participants to make it a robust sample. And so, as I mentioned, the survey was implemented and started in July. And every one of the waves for those 23 countries, we averaged between 3,000 and 5,600 respondents per country per wave. So we're somewhere over 2 million participants at this point. If you go to the next slide, please. Within the Facebook platform, an advertisement for the survey was published to individuals randomly within each country. And when a user chose to click on that advertisement, they were pushed to an outside server hosted by MIT. No personal information was carried over with them when they entered the MIT server. And they were then consented and asked to participate in the study. All participants identified as being over 18 years old. If we go to the next slide, please. So the statistics that are presented in our dashboard are weighted. And this means that the figures are adjusted based on population estimates for each country. They're adjusted for several factors, including things like non-response bias or people not actually answering all of the questions and using post-stratification techniques. So these steps are taken to adjust the data in a way that best reflects the general population. And so that policymakers can then take these data and use them, somewhat trustingly and confidently that they are actually they're going to provide insights for what's happening in their country. You can go to the next slide. When we launched the survey, global focus was on prevention, and that is reflected in the survey domains, which include things like the sources of information. So where do people get their information about COVID-19, and what types of, even though they may get their information from one place, do they actually trust it? And that's really important to know. So when you start pushing dissemination, you start disseminating messages that people are getting the message from someplace that they trust. And also we ask questions about their risk perceptions. Did they feel like they were at threat if they became sick with COVID-19? And understanding how that's related to their behaviors, as well as things like social norms. Are people in their community wearing masks? Or are people in their community, do they believe that people in their community are washing their hands on a regular basis? And there are several other topics as well. So this is a data utilization project. If you go to the next slide, please. Yeah, this is a data utilization project. And so transparency is important for us and for our users. A benefit of working with Facebook is that they have their immediate access to more than 2 billion users. Surveys were often fielded for about 5 to 7 days, and we had relatively robust sample sizes. Despite the large samples, there's limited granularity to these data. For example, like when you go into the dashboard, you'll notice that we've dichotomized a lot of the demographics. So people are either over 30 or under 30. They either live in urban or rural areas. There's not a lot of detail about, and we're not able to kind of slice those demographic groups into smaller units, and that's unfortunate. Because when you go to a resource like the DHS or other kind of big surveys, they are able to kind of give you those 5-year age increments. So, but what we do know is that our data are a little bit skewed, even despite all the weights I talked about a couple slides ago. And we notice that our data are a little bit more educated, and they're often more male, and they obviously, because of the way in which we collect the data through mobile phones, we really don't capture data from hard to reach populations. So we have to be transparent about that and make sure that's put out front, and people understand that when they're using these data, because there is other work that needs to be done, and we'll talk about that a little bit more about ground truthing and putting these data and finding out the important details that are contextually relevant in each country. We have compared our data to other mobile phone-based sampling methods, and we've noticed some of the challenges with those phone-based sampling methods. They often don't come with weights and kind of allow more generalizability, and they usually just provide you with data that you get, and not making those adjustments. But being transparent and making sure that both in a situation like the pandemic, you have to pull the data that you're able to get with the funding and the resources that you have, and so just being transparent is really critical in this process. So next, Marla is going to start to walk you through the dashboard, talk about the features of the dashboard and how it was developed, and some of the rationale behind that. So hand it over to Marla.
Thanks, Dominic. So as you see here, there's 5 separate dashboards that have been developed from this data. A global and regional dashboard reflecting cross-sectional data from all 67 countries. That's the first one you see in the upper left. An individual country view that provides cross-sectional disaggregated data for all 67 countries. A dashboard that's specifically focused on the United States and India, and that provides a regional level breakdown of data. A longitudinal dashboard that was updated with 19 waves of data. The last wave ended on March 29th. And the most recent addition is a multi-pane visualization on vaccine acceptance data from both the cross-sectional countries and the longitudinal countries. Now, it's important to note, and click, the animation should pop up. There we go. And the vaccine acceptance, and then click again for longitudinal. Okay, those 2 have been updated every 2 weeks since July. The others contain the data that was only, the survey was only administered twice, once in July and once in November. Next slide, please. So how do you deliver the results of a behavioral focused survey of over 2 million people on knowledge, attitudes, and practices and not overwhelm them? How do you display the data in a way that practitioners and policymakers from the 67 countries surveyed can easily access and use in their work? But our aim is to focus on key behavioral insights with tailored interpretation, as well as links to health communication resources to help users address gaps in the adoption of prevention behaviors, and later on in the project specifically address vaccine acceptance and hesitancy. Next slide. Our team took a user-centered approach by first offering a big picture view of the data on behavioral interventions such as mask wearing, hand washing, physical distancing, as well as risk perceptions and perceived norms. Users learned how to interpret the visualizations before drilling into their own country or regional data. And of course, we wanted to be engaging, not just full of eye candy or full of charts, but we wanted people to really click in and dig into the data. If you look closely at the side, you'll see that users have many options to go through the data. So the process started with creating personas, and our aim was to make each dashboard view tied to a specific goal for a specific audience. So those audiences that you see here, policymakers, public health officials, and officials at the WHO, that was our audience member persona that we were developing for. So we developed the visualizations by asking this question. If you click, as a stakeholder group or a member of these audiences, I need some kind of information so that I can do something. This led us to take a more journalistic storytelling approach to the data for these 3 key audiences. Next slide, please. Now, as I mentioned, we wanted users to go, oops. beyond the data. My moderation panel's up. There we go. So with our audiences identified, we set about the process of design, which included, as you see here in this introductory visualization, an overview of the data, a map to orient the user to the country data being presented, as well as instructions on how to interact with the data. This icon here, if you click, which we dubbed the Insights icon, was mentioned repeatedly by users as being highly valuable when viewing these data visualizations. So when on a particular visual, this icon provides behavioral insight into the data. I'll come back to the Insights icon and just say a few words on the tech considerations. We needed a platform that would be easy for the user to access and one that would easily handle frequent data updates. So for this series of dashboards, we used Tableau as a visualization platform and hosted on Tableau Public, which is a free platform to host on. So through Tableau, users can highlight or select a country within the graphic itself. This provides a hyper-focus and comparison options as we made the choice to provide country and regional data so the audiences could compare their data with their neighbors. We also wanted to have the ability to interact with the data, and I'll give a quick demonstration on ways to do that. And if anybody would like to talk specifically about Tableau as a platform choice for visualization, I know Dominic and I would be happy to have that discussion. Next slide. Now, as I mentioned, each visual poses a question to the audience and answers it with the data. In this example, how have behaviors, practices, and norms changed from July 2020 to March 2021? There are 5 ways to interact with this data. One, if you'll click, is the selection of the survey measure. This is where you choose one of the 8 survey measures particular to this visual, and you pick which one you'd like to investigate. And there are 10 unique visuals total in this particular dashboard, each one with different questions to filter by. Some have data disaggregated by male, female, or urban, rural. Next, if you can click again, perfect. You can highlight the WHO region if you wanted to focus on a specific set of countries. And when you click on this on the live dashboard, these countries will be highlighted in the map. So another way to interact with the data, if you can click, is where you see the measure of the wave results visualized in this chart, ranked from the greatest percentage point change to the least percentage point change in reported behavior from wave 1 to wave 19. So that's really small to see, but the United Kingdom has the largest percentage point change over the 19 waves of data collection in terms of mask wearing. Next slide. When you hover over any of the bars in this visual, if you click, oh, good. You'll see an embedded chart specific to that country, visualizing the reported percentages at each of the 19 waves. Throughout the dashboard, there are many instances where you'll see country-specific charts inside a larger visual, providing more detail. Next slide. So another way to interact with the same graphic is by hovering over a country. In this slide, you'll see the WHO's European region is highlighted, and I've put the cursor over the UK. This reveals a tooltip with additional country-specific information about the percentage change along the survey measure identified. You'll also notice, if you could click, there are color-coded, there's a color-coded chart at the bottom to represent the increasing or decreasing of the percentage point change. So the countries in the map are also color-coded, as well as the bars in the charts. Next. And one more way to interact with this graphic is through the Insights icon. So if you click, and then click again, yeah, when I click on it, I find a custom analysis specific to this visual. Now, displaying and visualizing data is helpful, but the next question a person naturally asks is, how can I use this in my work? So here is information not only how to interact with the graphic, but also its public health significance. Next slide. I'll quickly mention the vaccine acceptance dashboard as it has different visuals than the others. For instance, this timeline of vaccine-related events worldwide is positioned along global data on the 7-day moving average of cases and survey data related to global acceptance levels and a percentage of those who have been vaccinated along with those willing to accept a vaccine. All of that is displayed here. Now, the link to all these visuals will be shared in the last slide. And we can also put it in the link to the chat, put a link to it in the chat as well. Next slide. Now, as we know, the nature of the pandemic has changed quickly, and one positive change is the introduction of vaccines into the market. Here you'll see, if you could click and then click again, if I click on a country, there we go. You'll see in week 15, we started to receive data. That's the dark green chart in the lower left-hand corner. We started to receive data from those who've reported that they've already received a vaccine. So questions around vaccine update have been refined for an upcoming version of this study, which will launch mid-May, and Dominic will talk more about that. Next slide. So utilization. I'm sure many of you have heard the saying, if we build it, they will come. And we know that is not true. And it's especially not true with dashboards. So I'll move now to how we went about promoting the use of this data to our intended audience so they could implement it in their program and policy work. Next slide. So the components of our data use strategy are what you see here: blogs, insights and analysis included in the visualizations, which I just discussed, webinars, RCCE materials, templates for people to use. We'll talk about that. And then capturing use case data through a feedback mechanism. And then just a side note, this chart to the right, that's visualizing vaccine acceptance, is called a plum pudding chart. And Dominic and I found this to be a really useful visualization throughout, especially to demonstrate what it takes to get to herd immunity. Next slide. So our center at Johns Hopkins for Communication Programs, as well as our partners, that's a Facebook for Good post on the left, supported the effort with blog posts promoting findings in the data to support and encourage use among our audience and to capture new users. So every time we released a dashboard, we released a blog that had findings that were specific to that point in time and what the data was telling us. Next slide. I included this because this article that you see on the left from the WHO just came out yesterday. It included data from the KAP COVID survey. And the press release on the right is from the International Federation of Red Cross and Red Crescent. Two examples of how the data was reaching our intended audience through online media. Next. Right, so this is a sample of a series of social media graphics we sent out to our country offices on the Breakthrough Action Project, which is USAID's global flagship social and behavior change project. And we did this around specific topics. This was a series on trust. In each country, you would see, and these graphics are in the dashboard. They're just very small versions of them. You'll see which outlets, channels, and types of individuals garner the most trust among survey participants, as well as which ones have the most exposure. And this is over time. So on the dashboard, this is animated, so you can literally see the movement of different sources of information as they increase and decrease in trust level. We also included insights and sample social media messages for teams to use as is or to write their own posts from. Next. We've also seen other people adapt the data from the dashboard and create their own visualizations for use on social media. The yellow charts on the right are a country comparison between the US and Canada that a professor in Canada created. And the one on the left is a country comparison on vaccine acceptance. Next. We held a series of webinars that you'll see here. Our WHO colleagues supported the November 11th webinar, which you see on the left. And in turn, Dominic will be speaking at May 4th's Infodemic Management conference that WHO is holding. Next slide. So we also created a custom presentation to support these RCCE events, which Dominic will talk more about. So we created this template and posted this PowerPoint file that guides the user through the steps to create a custom presentation using the data and the visuals from the KAP COVID dashboard. Now, this presentation can be used in RCCE activities, Ministry of Health presentations, partner presentations, academic presentations, all to inform risk communication. Next slide. All right, so now I will turn it back to Dominic for some lessons learned.
Yeah, thanks, Marla. I mean, really, there's a couple of lessons. You've heard a little bit about them already, and so, I think you can kind of hopefully sense that this has been a pretty interesting and fun project for Marla and I to work on. It's something different from our everyday positions, but it's also kind of opened our eyes to the fact that there's a huge gap around social behavioral change projects and the data related to what's needed to develop messaging. The gap is particularly apparent in the low and middle income countries where most of our work takes place. And we understand the limitations to the data that we've shared today, and I talked a little bit about that at the beginning. But really, there's such a gap here that kind of getting anything kind of starts to push these countries and the program teams and strategies in the right direction. Often, as I mentioned, the granularity of our data isn't able to kind of slice and dice the population and give a lot of insights that are very refined. But the data that we provide on the dashboard definitely give countries a first step toward building a more comprehensive picture of what their messaging and what their strategy should look like. And so hopefully countries and RCC committees, like I'll talk about in a minute, are using them. If you'll go to the next slide, please. So risk communication and community engagement committees. This is an organization that is, kind of developed through international standards led by the WHO. And so in each of the countries and where we work, countries like Nigeria and Ghana, the Philippines, they have a committee, and this committee convenes to talk about and develop their national strategy to address pandemics like COVID-19. Team members, our team members in the field in these countries, as well as partners that we work with through Johns Hopkins CCP, have delivered and shared data from the KAP COVID dashboards in these RCC committee meetings directly and shared them with their colleagues, which influences policy decisions and next steps toward messaging. Also, our data are featured within the RCC guidance document, which was released in January by WHO and GORN, which I mentioned before, that you can see here on the left. If you'll go to the next slide, please. Some other ways in which these data were integrated into kind of global or regional activities include things like one activity in Jordan at the American University of Beirut. Myself and some colleagues provided a presentation and discussion of some social behavior change models. We talked about the survey content and the methodology and the implications of that. We focused on some North African and Middle East countries that were relevant to the people who were participating in this long-term workshop at the university. We provided the participants with a chance to ask questions about the data, talk through kind of that processing and developing messages and what some of the next steps would be in their countries. If you'll go to the next slide, please. Okay. Our team gave a focused presentation on the longitudinal data to some staff from UNICEF who are working in the MENA region as well, in the Middle East and North Africa. And the data was focused on, in this longitudinal presentation, it was focused on Egypt and Pakistan. And we were talking about some of the trends around COVID prevention and vaccine acceptance data that we had, and talking through some of the implications of that. So we also provided some suggestions for those next steps toward message development in the countries, what additional data and research would need to be collected to kind of ground truth some of the findings, as well as kind of differentiate the population a little bit for those messaging. So often, our work kind of results in the need to kind of implement some rapid research and validate findings and test messages, and that's kind of a continued theme that you hear. So within the dashboard, Marla very smartly put in like a feedback mechanism. So if you go to the next slide, please. Within the dashboard, Marla put in a feedback mechanism that allows people to give us some comments and feedback, which varies, like questions about methodology, questions about sample size, things like this, but also questions about, or actually responses about how people have used the data. So we got one entry was received from a behavioral scientist named Cheryl Jones. She works for the Caribbean Public Health Agency. And Cheryl told us that this was the only type of data that they had for the entire region. And it's important to note that there were only, in our data set, there are only 2 Caribbean countries, Jamaica and Trinidad and Tobago. And Cheryl mentioned that the dashboard was used to inform and develop key messages to address vaccine hesitancy. If you'll go to the next slide, please. Another country where the data were directly integrated into the COVID strategies is Indonesia. Through our country representatives, data from the dashboard were presented regularly at RCCE meetings. They were cited in the national COVID strategy and included an expert discussion panel with the Office of the President of Indonesia. Okay, if you'll go to the next slide. So we have completed 19 waves of data. Right now, this project is on a pause, and that pause is kind of exciting because we're not collecting any data. But right now Facebook is combining our team with teams from Carnegie Mellon and the University of Maryland. Our team will continue to promote data utilization in the next phase of the project. And right now the survey is being finalized with a vaccine focus. Data collection will be weekly moving forward. It won't be the 19 waves we collected. I didn't mention this earlier, but they were collected every 2.5 weeks to 3 weeks. Moving forward, data will be collected weekly. And the sample size is supposed to be even larger, providing more granularity. And it will also include more countries. So the new dashboards and visualizations will be developed, and we're hopeful to carry over many of the components that Marla described today to continue and increase that interactivity that's available in the present dashboards. So what I'm most excited about is we're actually going to build out a dedicated space for the RCCE committee members, kind of a one-stop shop, someplace where they can go download a PDF file or a PowerPoint presentation and kind of take it to their meeting and share it with the others in the meeting. And so, we may be looking to others for some feedback on this, and when it's up and available, hopefully people will use that feedback mechanism to help us refine and improve that tool. All right, and we really appreciate you coming to the meeting today, this presentation today, and thanks for listening. And this is our contact information, and we're happy to answer any questions you might have for us.
Wonderful. Thank you, Marla and Dominic. That was actually amazing. Really a beautiful way to show kind of end-to-end from your survey methodology to how you're displaying the data and how the data you're facilitating, making it used. So thank you so much for sharing that experience. We do have a few questions and we have about 10 minutes left, so that's perfect. So I'm going to start from the earliest ones that were shared. So there's a question: was the demographic info on your participants collected from Facebook, or did the participants self-report that once they were taken to the MIT site to take the survey? I also had I've never conducted a survey on a platform like Facebook, so I also had a lot of questions about sort of like, was there IRB approval? What did informed consent look like? Can you guys speak a little bit about that?
Absolutely. So no data that is in Facebook made it over to the survey unless somebody entered it in the survey itself. So no data was carried over. And so there was an informed consent, and IRB process was reviewed by the IRB at MIT. And so that was part of the process, and there was a formal consent process that every participant went through. But yeah, if I wasn't clear before, it is important to understand that any data that's in Facebook did not make it into this survey unless a person entered it into one of the response options.
Good to know. And yeah, I think a different question, I think a lot of folks would be interested in how you sort of worked with Facebook and what that looked like. So maybe another presentation, but yeah. I'm fascinated by that. Another question from Jess: great use of the tool tips to include analysis notes. How often does an analyst complete this, and is any of that automated? For instance, are the analysis responses templated? That's a good question.
Yeah, what do you think, Marla? Answer that?
Yeah, so we're looking into that feature for our KAP COVID round 2 of dashboards, because that has been the feature that people respond to the most, the insights. They're not automated, and we need to review them. We needed to review them every time we did a data update to make sure that the examples that we were giving were still accurate. For example, in the last wave of data, we saw, unfortunately, a significant movement and decrease in mask wearing in a number of countries. So we used an example, showing percentage increase and decrease in that insights icon, and we had to manually change that because those numbers changed on us. Mm-hmm. So it's probably, yeah, Dominic, I would also say, I mean, it's a challenging aspect, and it's so valuable, but it was a lot of work.
Mm-hmm. One of the things, when you go to the dashboard, you'll notice that there's summary statistics. So it's really descriptive data that we've presented. We haven't really put in any regression analyses or anything that is more advanced, even t-tests or chi-squares. None of that is in there yet. But we hope that moving forward, we can include those pieces. One thing that's interesting too is if you want the data, the full data set, you can download that. It's available through Facebook Data for Good, and it's available. Then you'll answer some questions, and they'll send it to you in a few days. But I haven't heard any issues with people getting data. And actually, yesterday there was a publication that we didn't know about that came through my news feed and was using these data in their analysis. And so it's really moving forward. We hope that we will have a little bit more automation. But we were a little bit nervous about that in the beginning too. So this is also a huge learning curve for us in terms of how we can do this and how we can put some data up. The other piece we hope to have in the next visualization is downloadable summary statistics. So if you see a visualization, we're hopeful that you can actually download the data behind that table, or the table behind that visualization, sorry. And so that would, if people do want to make their other visualizations on their own, like Marla mentioned in her presentation, we're hopeful that's going to be part of a feature of our data, of our dashboard.
Thanks. I think that was a really compelling part of the presentation, of how easily you made it available for folks to do their own analyses. Much of my work currently is on PEPFAR, actually, and there's a huge amount of interest in sort of, it's not really causal, but at least correlating COVID data alongside HIV data, and to know how it'll affect people's ability to access care and treatment, et cetera. Mm-hmm. So I know there's a lot of thirst for those types of data sets in the public health community generally. So that's really exciting. We do have a question from someone, I think related to that data set question. These dashboards are beautiful. Were they drawing from a static data set, or were those that updated dynamically, drawing from a dynamic data set as surveys came in? I guess the question is, was it sort of a manual push to your Tableau public server, or was there sort of like an API, or it was updated dynamically?
Yeah, it was a manual push and a lot of work by a few people. Marla, do you want to talk a little bit about Tableau as a platform?
Yeah, and then a little bit more about that. So yeah, it's as Dominic said, we would deliver summary statistics to our data visualization partner, and so each wave would be manually updated and pushed live to Tableau. I agree. I think that Tableau does create beautiful visualizations. Overall, it's really been wonderful to use this platform, because it does, tell the data story, and that's what we wanted to do. As I mentioned, introduce people to all that you could do on the dashboard, and then, get people to the point where they're making a decision of exactly what they want to be looking for, and be able to use the filters within the visualizations to get the information that they need. Tableau Public, sometimes we've had some issues with speed and uptime, but that was the trade-off that we made for using something so accessible and free.
Yeah. While we're on the subject of Tableau, another question from Jess saying, love that you created PowerPoint templates for users to leverage the dashboards. Agree, that was very cool. Did you consider using the stories feature of Tableau? I admit I do not know what this feature is, so perhaps you know, Marla. Did you consider using the stories feature of Tableau, or were there concerns about accessibility and user learning?
Yeah, so one thing is, I was a former school teacher for about 10 years, so building out a template like this kind of made sense if you wanted people to pull the data down and actually actualize it in a presentation. Giving them as much, moving them along that process as far as possible was really what would facilitate that. If you go to our vaccine acceptance dashboard, that actually uses the Tableau story feature. I believe it does, and it has several different panes that you kind of click through, and then you can interact on each of the different panes. And that was the last dashboard we built, and it was kind of presented to us as an option, and so yeah, it was a fun process to go through, and it kind of made us think a little bit differently about how to organize the data and tell the story in that presentation.
So we have about 1 minute left. We do have one last question. If the data is publicly available to be accessed, used by others, and if the any analysis potentially is applied more broadly, did you address potential IRB or HSR requirements? Good question.
Yeah, so this study, the study behind the dashboard was fully reviewed by the IRB at Massachusetts Institute of Technology. And Johns Hopkins IRB also reviewed it and gave us permissions to use these. So yes, it is. And all
the concern we have in this room for human sub.
Yeah,
making sure that we're doing everything above board.
Well, I think too, collecting data on. I think what's important about this too is that collecting data on social media, not even on social media, because it's important to understand that the people click through to an outside server and to a completely different platform.
Social media.
Yeah, but I think the connection between the two, I think, creates a lot of hesitation, and rightfully so. And I think it's important to kind of weigh those decisions. And you know, as I said, our work got pushed to social media like very quickly after COVID happened, and I think it's going to be a big impact on how we move forward in our work in the future. So I think it's important to kind of start weighing and talking through these things a lot in terms of, you know, figuring out what the right kind of decision making is for each program.
Definitely a good note to end on. So we're at time. I know I speak for everyone who might not be able to raise their voices or that you can hear their applause, that we really appreciate this really great presentation. Thank you so much, Marla and Dominic. We will now have a 15-minute break, and there will be a panel discussion at the hour, and then there will be a virtual networking hour in the Gather tab. And just so everyone knows, I actually went to the networking yesterday, and it was kind of cool, even though it's very intimidating. So feel free to try it out. It might be a little weird to network virtually, but try it out. And again, just big round of applause, Marla and Dominic. I appreciate your time and your wonderfully put together presentation. Thanks so much.
You're welcome. Pleasure to do that.
Thanks, everybody. Have a good one.